Thank you. I must say that I'm grateful for the opportunity to share, in knowledge, share what we do in radiology, an opportunity for us to talk to ourselves as, believers in Christ, as the children of God, how we can empower ourselves and make ourselves strong, to serve God and to serve humanity. So I must say I'm grateful for the opportunity CMDA has given me. I wouldn't be here without the help of brethren. So I want to say thank you, a very big thank you. And without much ado, we'll now go to our lecture, our little talk, our discussion today, which is titled Imaging in Cancers and Cardiovascular Diseases, Essentials for Physicians. So essentials that would apply to, help our patients, to, care for our patients. Essentials also that we will also use for our family members and ourselves, as the case may be. So today we'll be looking at our talk, knowing that it is, a very, short time, but quite a number of slides we have to look through. So we'll be as, as fast as we can, so we can buckle up our seat belts. We'll look through, looking at it, using these, guidelines, our objectives, definitions, classifications of imaging modalities, looking at those imaging modalities and then clarifying which one would say would be the ideal imaging modality. And then we'll look at how we can apply these in imaging cancers and cardiovascular diseases. Of course, finally, we'll look at what the best imaging modality is for the greatest threat to our lives. And then we'll conclude. Our mantra, which we all believe in, is that we usually care, God cures, that we help, God heals. Now, who is that God that cares and that God that cures and that God that heals? He is the great I am that we see in the Bible. God is all good things to all people. And he is the great physician when we look through Matthew 15:30. And then he's the public health physician, he's a surgeon and an anesthesiologist. And then crucially for this lecture, God is a radiologist when we look through Jeremiah chapter 1, verse 5. The objective of our talk today is to remind ourselves of those radiological modalities and tools that we use in order to enable us to reach a definitive diagnosis for what is wrong with our patients. Today, we'll be looking at those imaging modalities, using them in terms of neoplasia and cardiovascular diseases. We'll also re-examine the medical algorithms that we need, to apply so that we'll get the best, of information in order to treat our patients, and then in the follow-up as well for these diseases. And then we'll look for the way forward for radiologists and physicians. Diagnostic radiology is the use of, energy forms in order to produce images of the human body. Neoplasia, as we know, is new growth. Benign ones do not infiltrate, while the malignant ones infiltrate, during their multiplication and pass through several, tissue planes. So cancers, we know, or neoplasia, malignant neoplasia has multifactorial, causes. And the imaging needs, of course, would be important for us to use, apply different mechanisms, so that we can catch the disease at its very young age. The energies we apply are through the electromagnetic spectrum. On towards our left, the imaging modalities that have higher frequencies and shorter wavelengths are usually the ones that are ionizing. Ionizing radiations are those radiations that can alter the chemical bonds within the body, that can destroy tissues, while the non-ionizing ones have, a shorter frequency and a higher, wavelengths. Those ones we see on our right to the right side of the image of our screen. So diagnostic radiology is that aspect of medicine that would utilize these energy forms to create images and likeness, which will support medical intervention. We can classify them into, based on their, ionizing properties, into those that are ionizing and non-ionizing. The ionizing imaging modalities are radiography, mammography, fluoroscopy, angiography, CT. These are the ones that utilize the ionizing energies in order to produce images that we use in medicine. Those that utilize non-ionizing radiation are referred to as not as like MRI and ultrasound. And then we can also be divided into those that just produce, anatomical details of the structure that we're looking at the lesions, where are they located, what is their size, structural changes of the surrounding tissue. And then those that can produce function, look at the function of those cells, of those tissues, so those ones will produce molecular details. These ones especially will be our, positron emission tomography and, single photon emission computed tomography. So they give insight into the function of the body. And then we have some of the imaging modalities that, can combine both. So we do hybrid imaging. So the imaging modalities are radiography, sonography, fluoroscopy, angiography, CT, MRI. Of course, we have our mammography. Radiography is the oldest imaging modality, the oldest of the imaging modalities. Can identify lesions in millimeters and then greater dimensions. It is cheap. The man who first discovered it in 1895 is Konrad Röntgen. That is, a demonstration of how a technician is trying to get, and to image a part of the body. And then this imaging modality, radiography, can display, three-dimensional structures in 2 dimensions, meaning we would need 2 images at right angles to one another in order for it to be complete. Here we have, a chest X-ray, AP or PA, and then a lateral. We'll have an image of the ankle, AP as well as a lateral. So these images, it is ionizing radiation. So usually a caution is, sent out so that people will be careful not to just expose individuals indiscriminately, and then also to know how they go around that area. For those who work in the, imaging department, will have lead aprons that are able to protect. This lead is able to, stop, ionizing radiation. So we dress up like this in order to work in there. So these radiographies are available cheap, but contrast and, spatial resolutions are not very good. It uses ionizing radiation. Ionizing radiation implies that it can also cause cancers. The cancers we are worried about today, in very high doses, in repeated forms, it can also cause cancers. X-ray mammography, imaging the breast. So we have digital X-ray mammography, which we can apply contrast also for dense breast in order to help to screen the breast, to identify, breast cancers. We can do it in 2 forms, either a screening, which we can do for those over 40 years and above, and then for those who, already has the breast lesion, we can also use, mammography to help in order to make a diagnosis, especially for those whose family history shows they have breast, their family members have breast cancer. Those who've had breast cancers before, we can also do that. So that's, doing the study on the left, and then that's the image that comes out on the right. It is cheap available, but it utilizes ionizing radiation. It is said that about 0.005% of those who, get exposed to X-ray mammography will come down with, cancers later on. So, but it is a very, very small, group. Ultrasound is a non-ionizing imaging modality. We apply ultrasound waves, and then we can image every part of the body, the breast, the thyroid, the prostate, muscles, abdominal, viscera. It is the first imaging modality we utilize when we are imaging soft tissue. It shows the organs in cross section. That means it is better than our X-rays, which shows the organs and tissues and areas of the body in 2 dimensions. We can have surface probes and then or use endoluminal probes. So we can have esophageal probes. We can have transrectal probes. We can have transvaginal probes. So we can apply high frequency probes or low frequency probes in order to get our imaging. That is what the machine looks like. So, and then sonomammography, like I mentioned, we can apply it on the breast, to also, image women. This is what an image will look like. Of course, this our session, we won't be describing, in the terminologies used. But here we can see that's the liver, and then that's the liver here, and then the right kidney. the liver, the right kidney again, and all. So we can just identify the, organs, tissues, ultrasound images them quite well, and then ultrasound also can show vessels. So we can have a Doppler study, ultrasound imaging vessels. This one shows us, the circle of Willis in the brain. So it shows us clearly. So we don't need to have the invasive studies of angiography, conventional or catheter angiography. So with ultrasound, when we can image vessels from the foot down, to the neck, the carotids, we can image. So ultrasound helps us. What are the drawbacks? Ultrasound is temperature dependent, and then it can be limited and obstructed by bone and air. Fluoroscopy is, an imaging modality that utilizes X-rays. It shows the structure and then adds motion. We can now see movement of various organs. So we can actually look at the heart and all that. We can look at, structures, the stomach moving, peristalsis in the intestines. It can enable us also to take biopsies. However, ionizing radiation exposure is very high. So the exposure to X-rays when we do fluoroscopy is higher than when we do radiography. So that's what this fluoroscopic machine looks like. Now, this is the large bowel being shown on an NMR study. We say this is a double contrast study. We have air, and then we introduce another material we refer to as barium that is opaque to radiation. So with this, we can use it to identify lesions within the bowel lobes and the stomach. So the drawback here is ionizing radiation. It is expensive, and then it is not readily available. So you can see the drawback to this imaging modality. Angiography is fluoroscopy of the vessels. So in this instance, a catheter is introduced into the vessel, the arteries, the veins, and then we can inject the dye into this, into the artery, and then take films. We can also deliver drugs directly to a particular organ. It can also help in tumor vessel occlusion and then tumor ablation. Here we can see, on the left, we can see an aneurysm of the abdominal aorta. Well, that is normal. This one is normal. So that is what angiography does. It has a high radiation dose. It's expensive. It is also not a readily available imaging modality. Accidents can happen. Sometimes the catheters can be cut off, and then as a missile goes to the heart or goes to the brain. So accidents have happened in the past, so we are very careful. It is only applied in situations where we want to actually do an intervention. Otherwise, if it is to show the vessels, ultrasound, like I said, using our Doppler can show us the vessel. And then there are other modalities that can help us without actually doing this very invasive study. Computer tomography is using X-rays, so many X-ray tubes around an individual, to take images of that individual, and then using computers to, get a mapping of what the tissues look like. So it helps us. We can also, post-process the images we receive. We can make them darker, lighter. We can also reconstruct those images, in order to see what is going on. That is what a CT machine looks like. And then this is, a power injector that would deliver a required dose of contrast into the individual. So it images in multiple planes, just like ultrasound. So ultrasound, MRI, CT, these are, the cross-sectional imaging modalities that, would image the individual in cross-section, showing us the various planes. So the CT application, we can do an angiography, inject dye into the vein, and then, using computer, algorithm, we can get the various vessels in that area, either in the lower limb, upper limb, do the heart. We can do perfusion studies, coronary angios, we can also do. It can also, give a score regarding calcium within the major vessels, and especially like the coronary arteries. It can give us those. And then we can also look at the colon, and these days, there is also CT that can do with 4D acquisition, where we can identify, movement. The major advantage in this one, we're talking about attenuation units or values or Hansfield unit, is that CT can give value to every structure in the body. The bone, the hemorrhage, gray matter, white matter, CSF, water. So air will give you like minus, when we put the cursor and we see minus 1,000, we know it is air. When we have 0, we know it's water. About 1,000, we know it is bone. So this is one of the advantages. That these are CT images. On the left, we see it in the coronal plane. On the right, the axial plane. So it shows us all the structures that we need to see in the abdomen. This is also a CT study. The images showing us at the level of the chest. So this one is a reference image. That's where the study is. And then these are the, the lungs, the heart, and all that. So that is it. And we can also, like I said, we can have different, images. So we can have, this is, the soft tissue window. This is the lung window. So we can window and know what is going on. So it is very expensive, high ionizing radiation, not readily available. The radiation dose, when we do CTs, like a chest CT, one chest CT can be equivalent to exposing somebody 500 times doing a chest film. So exposing somebody 500 times, doing a chest radiograph, it will be the dose the individual receives will be equivalent to doing one chest CT. Magnetic resonance imaging, we use magnets, we use radio frequency waves and a computer to create an image. The better the magnetic field strength, the better the images that we have. Various sequences are shown. Various imaging modality, sequences we can identify. We can also do perfusion studies using contrast. So diffusion weighted images can help us, as well as spectroscopy when we are looking out for cancers. That's what it looks like. That is a radio frequency coil. So these are the images. That's a T1 weighted. And then when we give contrast, we can see this pathology, very clear here, at the level of the brainstem. So we can have, MRI also show us the vessels at the level of the circle of Willis. So we can also see the vessels. That is a T2 weighted image, So spectroscopy looks at the various chemicals and, and depending on their number, we can draw graphs that will tell us if the metabolites show, a tumor or not. So like in this case, when choline is identified, here we can see where the cursor is put. The metabolites here are assessed. And when choline is very high, we know that the lesion here is a malignancy, it's a cancer, it's a new growth. The same thing applies on this side. So the disadvantage is that you can't bring ferromagnetic objects in. It is contraindicated. And then MRI is blind to cortical bone. It's also very, very expensive. The good point is that it has great spatial and contrast resolution. It is the best imaging modality for soft tissue. Nuclear medicine applies, an imaging modality applies, an imaging modality that would identify, metabolic areas that are active, so areas that have large blood supplies. Areas that have large blood supplies, can be demonstrated when we give, the substrates that would eventually degrade and give rise to what? To the radiation we refer to as gamma rays. So this one, we can inhale it, the people can swallow, and then it can be injected into arteries and veins. And then that radiopharmaceutical will degrade, it is unstable. In order to gain stability, it now gives rise to what? Gamma rays. So gamma rays, instead of X-rays, is used in nuclear medicine. So they will have a marriage, a combination of a ligand or a substrate that will link to a radiopharmaceutical. The radiopharmaceutical is the molecule that will degrade. But when we link it up, it is carried to a place of interest. For instance, if we link, one of the radiopharmaceutical, referred to as, technetium 99, when we link it to calcium, it will go to where calcium are most available. That means bones and joints, and then you can link it also to iodine. When you link it to iodine, it will go to the thyroid, and then it will demonstrate what is going on. So that is what happens. Now, what we have here is like using GPS, to get to a particular point, a destination, you link it, or using GPS as a car tracker. when once that, all the material is there in the car, wherever the car is driven to, we can, based on a remote location, we can identify it. Al-Kuwaiti is the guy who was followed until he identified, went to where Osama bin Laden was staying in Pakistan. So it's the same thing that nuclear medicine does. So you tag a substrate, you tag the radionuclide substance in, to a substrate. That substrate goes to where it should, be identified, and then it, it lights up the area. For instance, tetrophosphine, sestamibid, sodium 201 are ones that can be taken up by the atmosphere. While technetium can also go everywhere, like esdametazine is also one of the substrates that can image the brain. So that is what the nuclear medicine, looks like. So these are the gamma camera. The individual stays in between. The individual would have taken the substrate, and then the images are shown. So the two types, single photon emission computed tomography and then positron emission tomography. This one just gives us the gamma photon, and then the gamma camera identifies it. While this one gives us a positron. The positron interacts with an electron, and what the energy that is given off is identified by the gamma camera. We can use it in terms of tumor imaging. In fact, it is the best modality to image tumors, neoplasias. You can identify everywhere the tumor is, and then we can also image the heart muscle. So that is what it looks like when we image the brain. So the lighted areas are the areas that have the substrate. And then this is it again, showing us the kidneys, the urinary bladder as urine with the radionuclide, it's identified. So we identified them, and then that's the heart here. So the same thing showing us around, the kidneys, and the various structures where it is identified. Theranostics is applying the nuclear medicine in order to make the diagnosis as well as treat. So we can actually treat, use it, attach it to certain substrates that will go to certain areas like iodine 131. It will get there, and then it will take care of, hyperthyroidism and thyroid cancers. So, or radioactive iodine. So we use it. So that is the newer thing. The disadvantage is very expensive, not readily available. In the whole of Nigeria, there are just about 4 centers that have radionuclide imaging, and then the radiation dose is very high. Hybrid imaging is when we couple these two images modalities. We do a PET, nuclear medicine, and CT, or ultrasound and MRI. It is referred to as hybrid imaging. So in this case, look at this study, pre-chemotherapy, that's the heart being demonstrated, but that's a tumor here, in the abdomen. And then you send the nuclide to it, and then when it is ablated, when it is destroyed, clearly it is no more. And then that's a CT, and then the radionuclide identified the mass here in the bowel, and then it is ablated. So the same thing, that's our CT, and then the radionuclide highlights it. The same thing here, the baseline, those are tumor cells, and then when you give 10 weeks later, we cannot make it out, 18 weeks, we can see if it has returned. So that is what happens. What is the ideal imaging modality? The ideal imaging modality is that would not utilize ionizing radiation. Will show, clearly normal, tissues, organs, and abnormal ones. Will be readily available. It will be cross-sectional, will be cheap, good spatial and contrast resolution, and then the risk of radiation is reduced. You will agree with me that no imaging modality can fulfill all this we have said. Now, what is the best imaging for soft tissue? The first imaging modality is ultrasound. The best is MRI. CT, however, is better than ultrasound, but CT would use ionizing radiation. So when we have any problems, when we have any tumor, a tissue, or disease that would involve soft tissue, our first imaging modality we would request for will be ultrasound. The best will be MRI. The first imaging modality for the heart and the vessels, the best and the first is echo, while the best modality is MRI. CT can also show us. For imaging intervention in non-vessels, the first imaging modality of ultrasound, the best will be CT or MRI or fluoroscopy, as the case may be, but ultrasound will be the first. To image vessels, and intervene in vessels, our conventional or catheter angiography will be the best. The best imaging modality for the detection of neoplasia and metastasis in nuclear medicine. It is said that nuclear medicine can detect cancers as small as rice seeds in the body. It can detect it. And then after that, MRI, CT, ultrasound, and so imaging cancers. We know the Bible tells us that the thief cometh not but for to steal, to kill, and to destroy. If diseases are robbers of earthly lives, cancers are armed robbers. So the chances of cancer taking a life is very, very high. So cancers rapidly divide and then they infiltrate bodies. They don't obey the contact inhibition. They are rogue cells. So as we know, the etiology of most cancers are unknown. Most of the cancers, the etiology are unknown. But we know, of course, some of them, that they have links. The stimulus that triggers the cancer initiates it, and then that cancer never stops. So there is usually an interplay between genetic predisposition and environmental precipitation. So an image of cancer cells, benign tumor, malignant tumors. Benign tumors respecting the tissue planes, the malignant cells not respecting them. Then the weapons of our warfare in our spiritual warfare are not carnal, and then they are mighty. But the weapons we use in radiology, they are many, but they are not mighty. So usually it is combining multiple, imaging modalities in order for us to identify the disease condition. So definitive diagnosis of cancers are usually histologic. When we take biopsy or excise the mass, we do the histology, that is it. However, if cancers are metastatic and they've gone around the body, imaging can be definitive, because when we identify it, we know that there is no way these tumors can get, or these masses can get there without it having a primary. So multi-modalities are frequently utilized in order to make the diagnosis. These are those imaging modalities we have identified before. Now, when we are looking out for tumors, usually the advice is to screen, So screening, like for the breast cancers, screening for those after 40 years and above, those with family history for cancers, for breast cancers, would enable us to make a diagnosis. Computers these days are also aiding us in order to make a diagnosis. Ultrasound imaging in cancer can help us to detect and differentiate the internal characteristics of the cancers. Are the cancers cystic? Are they solid? Ultrasound can interact with the tissues too, to enable us to know what the elasticity is. Tissues that are cancerous are not as elastic as normal tissue. Fluoroscopy would image, like I said, using our X-rays. It can image cavities and lumens. And this enables us, for instance, when we cancer in the esophagus, we can do our, barium swallow or esophagogram. And then, barium gastrography, we can also, see. Small bowel enema, large bowel enema, these can enable us identify cancers within the bowel. But remember what I said, nuclear medicine would immediately identify the cancers if we, identify what tissues are there and then send molecules that will identify those tissues. It immediately lights up if there are cancers. By the time we identify it using enema, the cancer has actually grown quite big. Conventional catheter angiography will be useful when we want to intervene, in cancers. So it helps us. We can actually send drugs, chemotherapeutic agents directly to the cancer tissues and the organs that are cancerous, and then it can be delivered directly through catheter. And then we can also occlude the vessels that feed the cancer cells. So that is how it can help us. Nuclear medicine, using our gamma photons and positrons, can now image the tumors. So we can do PET scans that can show us normal and abnormal tissues. This one is the heart. It shows us very clearly better. This one, shows us areas where there are ischemias, So MRI also can be used in cancer detection, in staging, in therapy and response, to monitor as well as guidance during biopsy. We can also use it, to image. So MRI, perfusion imaging, diffusion imaging, spectroscopy are those, and then magnetic resonance elastography are those that can help us to identify. Also, mammography using MRI can also help us. When the X-ray mammography and ultrasound mammography are not very clear, they are, equivocal, we can use magnetic resonance mammography to help. So what is the diagnostic algorithm for cancers? First is we need to screen cancers, to do screening. So those radiology helps us in order to do the screening. So we can, screen when, for instance, people that have various genes, the BRCA gene 1 and 2 can, tell us individuals that will be susceptible to breast cancers, ovarian cancers. And then imaging can help us. We now stage, when there is cancer already, we have identified it, we can stage at what level it is. Where is the cancer? Is it, just in one organ, or one group of tissues that we can actually isolate and take away? And then during cancer treatment, imaging can also help us so that we actually make the diagnosis that the cancer is in remission or it is still, be increasing. And then clinical management and survivorship. So this is the diagram showing us what will happen. To screen, we need molecular imaging, like our nuclear medicine. And then initial symptoms, we can do the various, structural structural imaging or morphologic imaging, our CTs, our MRIs, ultrasound, we can do that. And then treatment will apply the same thing, and then we'll do that in follow-up. So biomedical imaging techniques are used at all phases of cancer management. So imaging forms an essential part of cancer clinical protocols and is able to furnish morphologic, structural, metabolic, and functional information. Now, note that the function will be deranged quite early. So if we use images that identify, the enzymes that go to that structure or the hormones that are elicited from that structure, we can identify the cancer even before it becomes very big. Morphological and structural imaging will now identify it when it is big. So metabolic imaging is the way to go. So this is, a diagram showing us what we do. We screen, do the biopsy, stage, have prognosis, guide therapy, recurrence. So we use it in screening, in diagnosis, in staging, in treatment, and in monitoring. So for, breast imaging, mammography would help us. Of course, chest radiography is one of those, studies that we can just do, as a screening modality. Ultrasound can also be used, but remember, ultrasound is operator dependent. So sometimes we might need to go on to do a CT or an MRI, but ultrasound can help us. This individual has prostate cancer, ultrasound can help us. Has liver cancer, ultrasound can, and all that. Endoluminal ultrasounds can help us when we're in cervical evaluation, prostate evaluation. So early screening will be based on the imaging probability, so that it gives a major contribution. So when we use it for diagnosis and staging, like I said, we apply all the imaging modality, anyone, soft tissue ultrasound, MRI can also help us in soft tissue imaging. CT, remember, we said it can help. Commonly, imaging modalities are combined together. They are combined. So in order to, for instance, see the bones clearly, if there are cortical bone metastases, CT would help us. Of course, nuclear medicine would help us because it will image wherever the tumor is in the body. It will help us. Hybrid imaging is when we apply CT so that we can make out the structure clearly, and then we see where we can even biopsy, which tumor is active and which is not active. So that is where it comes in. Now, in our staging, we have these staging, tools that can help us. Imaging, reporting, and data systems. We can apply for breast, we refer to as BIRADS. For prostate, we refer to as PIRADS. For liver, we refer to as LIRADS. So this is an objective way of looking at it to say, okay, if it is graded as BIRADS stage, let's say 5, it means that it's a metastatic tumor. It has gone far. If it is graded as 1, this mass we have seen in the breast is probably most likely benign, most likely. So that is, and for 1, BIRADS 1 is normal. BIRADS 2, it's benign, why virus 3 probably benign, so that is a lexicon that helps us so that anywhere any person is in the world, they understand if it is malignant or not. So look at, that's a chest film, like I said, we need 2 views in order to have a 3-dimension. Now look at a normal film on the left. Look at, these are what we refer to as cannonballs. So multiple, look at multiple rounded opacities, various sizes, all over. So this tells us that there is a tumor somewhere that has, metastasized and is now in the lungs. That is it again. That's a huge one here, a huge mass here, in this hilar area. So it might be a lymphoma, might be, a squamous cell carcinoma, whatever it is. That is our metastatic cancer again. Of course, for breast cancers, we have our mammography. So this tells us a lesion that is spiculated, a lesion that is, opaque, irregular margins within the breast. So with this, we can also do other things. This one tells us, this is an ultrasound image. So it tells us if it is cystic or not. This is a cystic image. We can also do that to help us. So that is a CT image and an ultrasound still image telling us, showing us metastasis within, So this is Steve Jobs, the man who, of course, made the iPad, iPhone and all that, very popular. So he died of pancreatic cancer. So if, that's the cancer being detected on ultrasound, this is the normal part of the pancreas. This is the head of the pancreas area. And we can see it is heterogeneous. The echogenicity is less than that of this area. So Steve Jobs, now if his tumor was detected quite early using nuclear medicine, and then, treatment may have been offered, the tumor may have been ablated, but somehow the thing progressed. Our tumor in the stomach. So that is it here. That's the normal. Look at the velvety appearance of the rugae in the stomach. This one tells us it's a stomach cancer. So cancer here giving us our core, apple core appearance. So that's a tumor within the rectum, So and then the other areas, that is it again, the apple core deformity, like the core of an apple. So and then this is tumor ablation, renal cancer. That is our angiography. So you do this and then you take the catheter to where the tumor is and then you take out the blood vessels before the surgeons will go there. That is a tumor, a CT showing us a tumor in the posterior fossa with ventriculomegaly. So in the chest, these are tumors as well, coronal as well as axial. So we see tumors, breast cancers, that's a CT image. So we can make out breast cancer. So that's the way it is done. And then our hybrid imaging, that's our CT with a mass, in the pancreatic area, the head of pancreas area. That's it being lighted up when we have the PET scan. So it lights up telling us that this is the active area, that we can take biopsies, that we can send, the chemotherapy agent or radiation therapy to. So the same thing is, applicable here. So our breast MRI mammography, so that's the mammo. We can see a lesion here. That's the same lesion. That's the patient, in the MRI scanner. So MRI mammogram is more sensitive than our X-ray mammography or ultrasound mammography. Angelina Jolie is a lady whose family history shows clearly that there is breast cancer. She has the BRCA gene 1 and 2. She has gone to do mastectomy, prophylactic mastectomy. So that is what imaging would help us in order to identify and then do treatments early. And then MRI would also show us, prostate cancer. This is for CAP very clearly, the same thing, here, so MRI would show us, and then we can image. Of course, Biden, former American president, has, cancer, prostate cancer. That also the King Charles has prostate cancer. That is C.S. Lewis, one of the great Christian evangelists, a professor of history. So he too died of prostate cancer. So that is it. When we have our PET scans, we can see the tumor light up clearly, cancer of the stomach and the liver. So it lights up and then we can make out cancer of the tongue. So that's our hybrid imaging. So that's the CT. That's the, the tumor is not very obvious here, but you can see how obvious it is on the PET scan. So the same thing, hybrid imaging, metastasis to the lung. Tumors cannot hide. It can run, but it cannot hide when we use PET scans, nuclear imaging. So that is what we can apply. When it is available, of course. When it is not available, we'll use whatever imaging modality is there. If it is ultrasound, we can understand and then identify cancers, look out for lymph nodes, and then we'll do our chest films, so you can see clearly there is a lesion here in the chest. It is not active. But look at these ones that light up. These are active. So these are the ones the surgeons will be planning to take tissues from. These are the ones who will also be thinking of how to ablate, So that is the way MRI and, hybrid imaging helps us. That's hybrid imaging using CT, hybrid imaging using MRI. So look at this huge mass here in the chest. That is it telling us that the wall is active. Look at it again. So it tells us how we can image. Bob Marley, of course, died of melanoma, so I bring him here to show us what can happen. What will be the future role of imaging in cancers? The future role is in, using it to screen, diagnose, everything we have mentioned. We in doing our cardiovascular studies, there are both structural or morphologic imaging as well as functional imaging. Almost all of them can apply. Echo can give you both structure, give you function. MRI the same, CT the same. So these are the imaging modalities that we can apply. Chest X-ray becomes a very important screening tool to identify cardiac problems, and cardiovascular problems. But of course, when we have to image the heart and look at it in depth, echo is the first imaging modality of choice. And then ultrasound can help us when we're imaging vessels. Now, CT, MRI, as well as ultrasound can also help us. So these are the imaging modalities. And then our angiography. Diseases that would, necessitate imaging modalities, using imaging modalities are these. So we are out to get a diagnosis, assess the risk for the patient, guide treatment, and then the monitor. When it is, for instance, ischemic heart disease, of course, remember we have to, usually there are non-radiologic imaging, non-radiologic studies, ECGs, enzyme studies that can be done. But when they are, equivocal, you go on to do our, imaging studies. So for thrombus, thromboembolism, chest X-ray, echo, vascular studies, MRI can, so our chest X-rays, it can show us so many things: the heart, the lungs, the vessels, nodules, and everything. So because of time, so the primary imaging modality to image the heart, it will be echo, as well as the vessels. Echo will be the primary imaging modality. We evaluate the valve, identify abnormalities, pericardial abnormalities, congenital abnormalities, and all that. We can also do stress echoes, using, the individual climbs the treadmill, or we can give drugs like dopamine so that the heart, heart rate increases, tachycardia, So the angiography can only be undertaken when we are to, do therapy, open a coronary artery that is occluded and all that. And therefore, so we can help us, we'll give contrast. CTs, we can image the vessels clearly, but we cannot do any intervention using CTs, but it will show us the vessels. And then CT can also enable us to, grade the risk of an individual coming down with an ischemic heart problem. So CT calcium scoring is also done using CTs. So imaging modality, MRI can also show us where there is myocardial scarring, and then also assess the heart, function. So the nuclear medicine, like I mentioned earlier, will use a radiopharmaceutical to assess blood flow of the heart muscle, also identify areas of reduced blood supply. PET and SPECT are those. So the chest here, look at the image on the left. Look at how the heart is globular. So this one shows us, the carina is played out. So this one tells us clearly that, the heart, there is gross cardiomegaly. The heart chambers are all involved, telling us it's a multivalvular problem. Also there is pleural effusion in this. So this is the benefit of having the chest X-ray. You image the heart, you look at the lung fields and all that. That is our echo. So echo would now image, look at, pericardium, if there is pericardial effusion, if there is dilatation, if the heart is not pumping properly, the heart muscle thickness and all that. It will identify cardiomyopathies. This is our angio when we need to intervene. So that's our, the catheter coming into the vessel to, open it clearly, So that is where there is stenosis on one side, and then look at it, it's been opened up. So when we need to intervene, in order, angiography as well. When we also need to intervene, we'll do the conventional angio. Otherwise, the CT angio, MRI angio will show us. Even ultrasound can image these arteries very well. Albert Einstein is one of those who had abdominal aortic aneurysm, and he died from its rupture. So the greatest scientist of all time. So this is our CT angio, showing us we can make out, the plaques all over, and then the dilatation, look at, also going down to involve the common iliacs, and then our CTA, which tells us, showing us our calcium within the artery, and then the occlusion, so it shows us the occlusion. We can also now do the angio to open it up, Pulmonary embolism, CT also will show us, that's the embolus here. That's the embolus here again. So we can actually diagnosis. So MRI would also, so that's the CT again, CTA, showing us the areas of occlusion. So that is how it works. Future use, would be applying all these imaging modalities, multi-modality imaging. And then artificial intelligence is coming in order to help the radiologist even to make better, and quicker diagnosis. 3D echo would also be used. Now, what is the best imaging modalities for the greatest threat? The greatest threat to our lives is the threat of not making heaven, the threat of sin. So the most severe threat is that. And the best imaging modality for us to be able to assess our lives will be, looking at the Bible. So the Bible is the most important imaging modality that we can share with our patients, also within ourselves, assess our lives where we are, to know if we have the disease of sin or if we are still free. All these, areas tells us, about what it means to serve God, Now, the Bible, like I said, the book must always be before us, meditating on it day and night, so that we are kept safe from the disease of sin. And then God will enable us to also serve humanity and bring others to Him. So take home is that number one, these imaging modalities, there are ionizing and non-ionizing. The non-ionizing ones are the best ones that we can use so that we reduce the chances of cancers. But it is combination of these imaging modalities that will help us when we are imaging cancers as well as cardiovascular diseases. The nuclear, medicine approach is the best in terms of identifying cancers, because it will cancers can hide, they can't, they can run, but they can't hide. So it helps us. But however, any imaging modality you find, you can apply them in order to make a diagnosis. If in doubt, we ask the radiologist. So the functional biomedical imaging modality is a futuristic approach for early disease identification. The Bible is the imaging modality and tool to overcome the spiritual disease. And my references. Thank you. Thank you very much.
Once again, we want to thank you, sir, Professor Chukwuemeka Iagi, for this erudite lecture. We want to say thank you for having presented to us. By way of summary, I will just please apologies for one of our moderators, Dr. Gideon, who is having a challenge with his microphone that have taken this session. The speaker gave an insightful lecture on imaging cancers and cardiovascular diseases, essentials for physicians. He started by saying we care, God cares, we help, God heals. He let us know about the objectives, definition. He also took us through a broad spectrum of some level of physics, electromagnetic waves. How do we diagnose in radiology? He gave us different imaging modalities, radiography, ultrasonography, fluoroscopy, angiography, CT, MRI. He went further to also let us know the X-ray mammography, how the various types, the digital, contrast, screening, and diagnosing mammography. He also gave us know about the advantages and disadvantages of them. He went further to let us know about angiography, particular showing us some videos about the abdominal aortic aneurysm, advantage of them. Also went further letting us to know about CT applications of this, such as the CT angiography perfusion studies, coronary calcium scoring, which is also with 4D acquisition. He went further to let us know about nuclear medicine, of which he let us know about work of radiation. When it's injected into the body, it's just as how your nuclear weapons explode, it finds its way and brings out the desired impact. He also let us know that most times we prefer the non-ionizing radiation because of the level of cancers, which they may also cause, but for effectiveness, both ionizing and non-ionizing radiation are used. He also let us know about hybrid imaging, the PET, the SPET, and ultrasound, of which we say the ideal modality, imaging modality in this PET, because it utilizes non-ionizing radiation, show the normality or abnormality, is readily available, is cross-sectional, is cheap, has good spatial resolution, good contrast, and has less risk of reaction. Also went further to let us know the image of cancers, for where he quoted John 10 verse 10a, the thief cometh not but for to steal and to kill and to destroy. If diseases are robbers of earthly lives, cancer are harm robbers. And he let us know that what cancers are: rapidly dividing and proliferating, infiltrating cells that do not exhibit or obey contact cell inhibition. Let us know briefly how the pathogenesis occurs, the radiologic diagnosis, and what can we do for this cancer. Say we can do radiography, AP or lateral, X-ray mammography, fluorography, angiography, CT, ultrasound, MRI. And he told us that for screening 40 years and above, X-ray mammography, and which is far with those with familial history and computer-aided diagnosis. Fluoroscopy went further to tell us about MRI, the types, and use of radiology in cancer diagnosis, where it talked about the BRAT, PRAT, and LIRAT, both for the breast system, the prostate, and the liver system. He went further also to let us know about people that may have died from this cancer, some popular social media persons. Angelina Jolie, which was diagnosed, she went for mastectomy. We also had Bob Marley, which died from melanoma, and cardiovascular disease, which he gave us the different imaging modalities, where in Proverbs 4:23, say, keep thy heart with all diligence, for out of it are the issues of life. He did a lot, and geography said a lot, and finally, he gave us a take home that is a multi-modality approach in identifying threats to life. We need to monitor treatment, recovery, as well as make prognostic determinations, while functional biomedical imaging is the futuristic approach for early disease identification. The Bible is the imaging modality and tool to overcome spiritual diseases. Once again, sir, I want to thank you for that great lecture. We're just going to questions and answer time. There are some questions on the chat boxes. Sir, Professor Agisa, I don't know that you have read the questions, or I should just read them out for you, sir.
Read them. I've not looked at the questions yet.
Okay, sir. One of the questions says, is there any difficulty in making a diagnosis of mesenteric tumor using MRI? MRI made a diagnosis of... Hello, sir.
Okay, there's also another question.
Yes, I'm taking them one at a time.
Hello. Yeah, there's also another question here. Dr. Feb.
Yes, I'm taking them one at a time. I said the first question says,
should I answer or I wait until you finish?
Read out all the questions, sir. Just read out all the questions.
Okay, sir. Okay, sir. Okay, sir. So the first question says, is there any difficulty in making a diagnosis, in making a diagnosis of mesenteric tumor using MRI? Since MRI made a diagnosis of ovarian tumor at laparotomy, it was a huge mesenteric tumor. That's the first question. Then
should I answer?
The second one, there's another question. There's another
Should
question.
I answer that one?
Okay, there's another question. This one says, hello, is there any chance for patients with metallic implants to take MRI?
So is
if
there
no, any alternative? Any chance for patients with metallic implants, maybe for fracture and all that and all that? If no, any alternative? So is there any chance for patients with metallic implants to take MRI?
Okay. So should I be answering or I wait when you finish, when we finish?
Okay, so let's just make the questions three. I think one question sent to me privately says, what's the role of interventional radiologist in this management?
Okay.
Thank you, sir.
Okay. So I start with the first one, mesenteric CA. Now, remember what we mentioned, or part of it, maybe I'm sure because of, we had a lot of slides and we're trying to go through them. The definitive diagnosis of a malignancy is when you do the histology. So MRI can identify and say, this mass, you can imagine a mesenteric mass. The mesentery is also where, when the ovarian tumors come, that is also where they occupy. Now, the mesenteric mass would have areas that are cystic, containing cysts, areas that are solid. That is exactly how an ovarian mass would be like. And when it is huge, you may not, you sometimes, even both the MRI, even the CT, they may not identify both ovaries, equally. So you can mistake, a mesenteric mass for an ovarian mass. Now, this is where we have to remember, when we make the diagnosis, you are very sure that it is a tumor, it is a mass, and if, spectroscopy is also applied, yes, because of maybe high choline levels, you can say it is a malignant tumor, but you won't be able to say which one it is. Histology will tell you. Therefore, a differential diagnosis will usually be given. An MRI differential diagnosis, an ultrasound differential diagnosis, a CT so an imaging differential diagnosis will be given. So yes, what it does is it will identify what the problem is. But what is the culprit? Histology will tell us. So that is why it is not that it's incorrect. It is just that probably they didn't give those differentials, because when we give the differentials, the surgeons now would know. And when the surgeons are going in, usually, even if you say it's an ovarian tumor, the general surgeons would also be there in theater. But if now imaging guided biopsies had been taken, the definitive diagnosis would have been made before. But the fear all the time would be that the tumor might seed into the peritoneum when you do that. So, but sometimes people do it knowing that they are going to clear off virtually everything. So that is why. So MRI can make that diagnosis of a huge mass within the abdomen. And then based on the texture, the appearance of the tumor, you can say it is a mesenteric mass or an ovarian mass. Histology would confirm. Now, the second question, the chance of somebody who has had a metallic implant doing an MRI, it is usually not advised. It is usually, dissuaded. People are dissuaded from doing that, from going under the machine, because if it is not well, if it is not strong with adhesions, then the magnet will pull it. When the magnet pulls it, it will pull that limb or wherever the ferromagnetic material is, and accidents have happened that way. So sometimes people want to risk it, but usually we say no. Instead, such a person would have to do a CT. Person would have to do a CT, in order to, a CT will be the second study that can be done. Of course, even with CT, sometimes metallic implants can have their artifacts, but it is better, it is less risky. So when somebody has a metallic implant, the person does not go under the MRI scanner. The other thing too I want to bring to our notice is that when we do in order for an individual to undergo an MRI study, there is usually a form. There's usually a form that the individual will fill. So that form, all these questions will be asked. Have you worked in the metallic industry before? Do you have any implant in your ocular implant, auditory implant, cardiac implant, any implant anywhere, metallic, you'll be asked those questions. So, it means that the person won't be allowed. Now, on the alternative, the person can do a CT. The person can do our X-rays. The person can do fluoroscopy, depending on what they want to identify, because fluoroscopy would also identify, the implants clearly and whatever. So depending, but if in doubt, liaise with the radiologist, the resident radiologist there, and then you are able to reach what will be the safest. And there is a friend of mine who, needed to have, an MRI done. Unfortunately, he had a cardiac, he had an implant, he had a pacemaker. So they came to me, and immediately I shouted. The doctors didn't know. They had actually paid for it, but they called me on phone, and I had to tell them, no, he can't go on that because he has a pacemaker. That's when, but of course I know, they would have filled the form anyway. I don't know if they have filled it and they said no, and it goes under the MRI. That would be an immediate death. The third question, what is the role of the interventional radiologist? The interventional radiologist is there to offer direct therapeutic assistance. So there is a diagnostic, and then there is this intervention part of our work. Right now, the city and the center that has the best equipment in terms of interventional radiology is the University of Maiduguri Teaching Hospital. Their CMD, Professor Hijo, trained with me. He has done further trainings in intervention. So that is where a few months ago we sent a patient with a renal mass to them so that they could occlude the vessels, so which they did, and then the patient came back. So interventional radiologists actually do what? They intervene using the imaging modality. So when we talked about the coronary artery dilatation, the cardiologists will be there. There are interventional cardiologists as well, but when we are using the angiography machine, it will be the radiologist actually maneuvering these catheters and all that into those vessels, and then they will take the images, and then they will also pass the stents and then do the dilatation. So that is what the interventional radiologist does. He assists the clinician, you know, like this one, when we are worried about a tumor, a renal tumor, they will assist the clinician to reduce the blood supply to that tumor, and then the surgeons can go in and remove it. Like this mesenteric tumor, that can also would have been done to identify what feeding vessels, and then you occlude them, and then, you know, and in instances when you need to dilate, you also dilate. For instance, somebody comes in with the chest pain that, you know, when imaging is done and it is identified that it is because of coronary artery occlusion, then the interventional radiologist with the cardiologist will be there, pass the catheter, you know, put in a stent and all that. That was done for Bill Clinton, the former president of America, so many years ago. That is being done even in Nigeria, like I said, in Maiduguri. So that is the role of the interventional radiologist, to intervene. So that interventional radiologist is a radiologist who is fully qualified, but that is his area of subspecialization. So, you know, there are, in radiology, we subspecialize using one, imaging, the imaging modality, and then two, the, you know, we do systemic as well. So for instance, there are radiologists that only interpret MRIs. So it means that if you give them CT, they say no, only MRI they are reporting, only CT they are reporting, only sonography they are doing, you know, radiography, people who are specializing in radiography. And then there are radiologists that, you know, specialize in, you know, the, you know, other areas, pediatric radiology. I am, you know, my interest is in pediatric and sports radiology. So, and then there are radiologists that will be maternal, you know, obstetrics and gynecology. There are those that will look at fetal matter, you know, fetal medicine. There are those, you know, that will specialize in imaging, maybe specific areas, maybe cardiac imaging and all that. So that's the way we go.
Okay, thank you, sir. Thank you, sir. Sir, we'll just take the last three questions there. Okay. Please, I think we'll end with the last three questions. Every other person with questions can send to us. So the question says, how safe is CT mammography in breast cancer screening, since it is an ionizing radiation? That's the first question. How safe is CT mammography in breast cancer screening, since it has an ionizing radiation? Then the second one says he wanted to find out is a fibroscan, what a fibroscan is, and what differences. A fibroscan.
Okay.
Fibroscan. That what a fibroscan is and what differences, or are there any different advantage from a CT or MRI, especially in hepatopathic chronic hepatitis, in chronic hepatitis, etc. Then the last one here says, can patients with gold implanted tooth from their religious beliefs, e.g. Muslims, in emergency situations go for MRI if it's indicated, or they must remove the tooth or teeth before such investigations are done? The last question again says, can patients with gold implanted tooth from their religious beliefs, e.g. Muslims, in emergency situations go for MRI if it is indicated, or they must remove the tooth or teeth before such investigations are done? Thank you, sir.
Okay. Well, how safe is CT mammography? To me, that is very, very unlikely for us to do. Very, very unlikely for you to do CT for breast lesions. Very, very unlikely. Yes, that capacity is there, but it's never done. Because, like we mentioned, there is our X-ray, the simple one, you know, the radiation dose is low. And then ultrasound. When you know you're not very sure regarding the X-ray mammography, because CT utilizes X-ray to produce its own images. So when you're not sure regarding the lesion in the breast, you go for MRI mammo, sonomammography, ultrasound. So that's the next two that we usually do. It's unheard of for you. Of course, if for instance, maybe somebody has metastasis and all that, yeah, you can actually use CT. But CT for mammo is a no-no. So that is not advised, that is not done. That has no real advantage compared to ultrasound and MRI. So, you know, if we do our ultra X-ray and you know, there are issues with it, maybe it's a dense breast, you know, then we actually go to ultrasound and then evaluate, and then the next one will be MRI. The advantage with the CT would not, it wouldn't be. So it's a no-no. It is not safe. You know, it is never done. Now, a fibroscan is actually almost like, you know, a scan that looks at like it's an ultrasound, you know, and that is when we're talking about the elasticity of tissues. So a fibroscan tries to identify, you know, what tissues, how thick, how strong, how resistant those tissues are. For instance, we can use a fibroscan, which is like an ultrasound, you know, it's an ultrasound actually, in hepatobiliary issues. So when we talk about liver cirrhosis, you know, a fibroscan comes in handy for us to use. So it is actually an ultrasound scan. You know, it is actually an ultrasound scan that will assess, you know, when the liver has cirrhosis, we say the liver is, you know, is scarred. You know, there is scarring, there is fibrosis within the liver and the liver tissue. So that is, it can be referred to as a fibroscan. So that is, you know, that answer. It's still ultrasound, you know, but it is adapted to be able to talk about the elasticity of the tissue, any tissue you use it on. So, and remember what I mentioned in the course of our talk. We said malignant tissues, you know, are usually less elastic compared to the normal tissue. So when you do that elasticity measurement, then you'll be able to reach a conclusion to say it is malignant or not. Then the next one is the gold, implanted gold. Well, this one too is not, as I speak with you, I will give us a guide. I don't know if gold is ferromagnetic or not. So, but if it is ferromagnetic, the patient cannot go under the magnet. The patient cannot go under. The patient cannot go under. We'll have to think of another modality that would enable us. Remember, whatever CT can do, most of the things MRI can do, CT can do as well. So whatever was the need for the patient to get under to do an MRI, a CT can deputize. You know, that is when we will now say no. Because of the contraindication, a CT would use, we can use a CT. And then if it is actually soft tissue, ultrasound can also help us. Remember, CT can, you know, image soft tissue very, very well. The drawback is just the radiation dose. So the moment we know that, you know, the patient has an implanted gold, we can put the patient under that play, under the magnet, because we are cutting disaster. So I think that is it. What is there another question again that I've not answered?
No, sir, for now, sir. No, sir.
Okay.
Once again, sir, we want to thank you for this time, and once again for giving us a vast topic, imaging cancers and cardiovascular diseases. For the slides, some people have been commenting, we'll find a way to send it across to you or through the board, lecture series, and we'll also want to let us know that for those persons that wish to see our prof, by the grace of God, I think next week, the Rivers State Port Harcourt is hosting all radiologists in Nigeria for their annual conference. I believe you can meet them in person and felicitate with them. Also, before we call for announcements, I don't know that Kanichi, Dr. Mwabiara, are you there? Can you just give announcement as we call it a day? Before we call it a day, are you there, please?
Yes, I'm here. Good evening, everyone. All right, so we want to appreciate everyone who have attended this program. We want to especially appreciate our own Professor Age for bringing out time to to come and teach us. So we are very grateful, and we know that whenever we call, you always answer. But we don't have a lot of announcements. Just to remind us that the Eastern Zonal Doctors Conference is going to hold from 25th to 28th of September 2025, and it's in Abakaliki. The links are in our groups to register, so please click on the link, register, and get set. There's also a pre-conference event from Monday to Thursday, 22nd to 25th September 2025. And the details are on the flyers that are usually sent to our groups. So we encourage everyone to attend. Once again, I want to appreciate everyone for attending this program. We are grateful, and we're also grateful to the Secretariat for hosting. Thank you so much. God bless you.
Okay, thank you, Dr. Kanichi. Okay, are you done? Sorry.
Yes, I'm done. Thank you.
Okay, thank you. Before we say the closing prayer, on behalf of the River State chapter, through our chairman, Dr. Kanu Chukwuemeka, we want to thank Dr. Ngalatu Ana, our director for our professional development. Then we also want to thank Professor Femi Ogudupe, the chairman of the committee. I want to thank our CEO, Professor Chimanoka, and everyone that has made it, the CMDA secretarial staffs that made sure we didn't have technical issues. I want to say thank you very much and God bless. We'll now invite our sister, Dr. Ifeniwa Newman, to lead us in the closing prayer.